Thank you for that kind introduction, and good evening, everyone. Wow, everybody still has a lot of energy this evening after 3 days of meeting. That's wonderful. So what I'm going to try and talk about today is just expand on the eligibility of CAR T-cell therapy in multiple myeloma. Clearly, we don't have a biomarker for deciding who gets therapy with the CAR T-cell in relapsed multiple myeloma. But what it's clearly going to be something that is going to evolve over the next few years as we get more and more experience dealing with this particular patient population. Unfortunately, unlike stem cell transplant for multiple myeloma, where age and performance status often is used as a way to select patients for therapy, while those things are still in consideration for CAR T cells, there are certainly other aspects related to the side effect profile of these particular therapeutic modality that's going to drive our patient selection process. So in that context, we'll just go ahead and get started with this particular question. Which of the following features have not been associated with shortened duration of response with CAR T in multiple myeloma? Age, presence of extramedullary disease, high-risk cytogenetics, and triple-class refractory status. Please go ahead and vote. All right, well, the majority of you have selected age, and we'll come to that in a second. All right, let me, oops, I think. All right, so when you think about the myeloma treatment paradigm today, I think we have a lot of evidence supporting what we do for the newly diagnosed multiple myeloma, and clearly that is an area that has improved considerably over the past decade. Now we are looking at PFS for those patient population of almost 5 years in the first line of therapy. I think we have a good sense of what we need to do for the patients in the the subsequent 2 to 3 lines of therapy, well informed by the data from multiple phase 3 trials, again showing a variety of different triplets that incorporates proteasome inhibitors, immunomodulatory drugs, and anti-CD38 monoclonal antibodies can really make a difference for patients in these particular lines of therapy. Now, where it becomes really challenging is when you have patients who become refractory to those 3 classes of drugs, and then what do we do to control the myeloma in those patients? Now, when you look at the outcomes, and it's important to start from this point because we need to get a sense of what happens to these patients. And multiple studies, including this particular locomotion study, has shown that the median PFS for patients with triple-class refractory multiple myeloma is roughly in the range of 3 to 5 months, and a median overall survival that is around 1 year. So it is in that background that we started studying many of the immunotherapies, including CAR T cells and the bispecific antibodies. And now we have 2 CAR T cells that have been approved for treatment of multiple myeloma, the idecabtagene as well as ciltacabtagene autoleucel. Excuse me. Both these are anti-BCMA targeted CAR T cells. There are subtle differences in terms of their binding sites, and both of them have been studied in patients with triple-class exposed relapsed refractory multiple myeloma with 4 prior lines of therapy. And there are certain differences in terms of the cell dose and so forth. Now, when you look at the efficacy of these 2 agents, you can see that the majority of the patients who receive CAR T-cell therapy, despite having advanced disease, do respond to this modality. Obviously, it's hard to make cross-trial comparisons given the differences in the patient population, but we are looking at anywhere from 75 to almost 98% response rate across the CAR T-cell products that we have. Certainly, there are also differences in terms of what we have observed in the durability of response in terms of progression-free survival. Again, 2 different trials, so hard to compare the 2. But suffice to say that in a significant number of patients with relapsed refractory disease, we can get durable responses with the use of CAR T-cell therapy. Now, when you look at the side effect profile, they're very similar across the 2 products. You can also see, again, 80 to 90% of these patients do get cytokine release syndrome, and about 18 to 20% of these patients also get ICANS. The good thing is, the smaller proportion of patients actually get grade 3 CRS or grade 3 ICANS with these 2 products. Now, it's not just that, even though both these studies, both these CAR-Ts have been approved in the context of relapsed refractory disease with 3 to 4 prior lines of therapy, We have data suggesting that these agents or these products can be used much earlier in the course of the disease. On the left-hand side is the data from the KarMMa-3 trial looking at patients with 2 to 4 prior lines of therapy, comparing it to a standard of care regimen, demonstrating an improved progression-free survival. On the right-hand side, you can see the data that was recently presented from the CARTITUDE-4 study, looking at a 1 to 3 prior lines of therapy patient population, comparing it to a standard of care regimen, again demonstrating a significant improvement in the progression-free survival in these two patient population. Now, how much more advantage do you get by using these CAR T cells in the first relapse or second relapse compared to the fourth relapse? We still need to get a better sense with the longer-term follow-up of these trials. So given that scenario, the question then is, what are the common challenges that we face when we treat patients with CAR T cell therapy? And this sets a stage for how we select the patients for these treatments. Certainly, we know that age is an important factor. The older patients are going to have more comorbidities. They will have more toxicity. And obviously, patients with underlying neurological problems, underlying cardiopulmonary issues are at more or at a higher risk to develop many of those adverse events that we associate with CAR T cell therapy. Now, one of the biggest problems that we have, again, faced in these previous trials as well as in the clinic today is the very rapid progression of disease in these very late-stage patients, which sometimes can make it very difficult to wait for this CAR T cell product to be manufactured and returned for infusion. Now, increasingly, we have a BCMA-targeted bispecific antibody that's already approved and in the clinic, and there have been several of those who have been on clinical trials, and we have an ADC that is targeted against BCMA that was also previously approved. So quite a few of these patients that we see in that fifth-line therapy have already been exposed to BCMA, and that is a unique challenge. And there's a variety of different mechanisms that have been proposed as a way of resistance to the BCMA-targeted therapy, including loss of target. Now, as we alluded to in that earlier question, extramedullary disease poses a unique challenge in these patients. We know that a lot of our patients who come with advanced disease have extramedullary disease that are often resistant to therapy, and even if they do respond to therapy, often tend to have a very short duration of response. And we have also seen that patients who come into CAR T cell therapy with high tumor burden often end up with more toxicity than patients who end up with lower tumor burden. The prior BCMA-directed therapy is particularly of interest given the availability of other BCMA-targeted agents. Now, again, when you look at the subgroup analysis from both the KarMMa trial as well as the CARTITUDE initial studies, you can see that there is benefit seen across the variety, all the subgroups, with the exception of maybe patients with high-risk cytogenetics and particularly patients with extramedullary disease. So given that scenario, what do we know about patients who have previously been exposed to BCMA-targeted agents? Now, Dr. Hansen's going to go into much more detail about the real-world data, but I just wanted to draw your attention to the study that was published, presented by Dr. Hansen at ASCO and ASH, again showing that patients with extramedullary disease are much more commonly encountered in the clinical practice, almost 48% versus 39% in the KarMMa trial. And of course, in the KarMMa trial, we didn't see anybody with a prior BCMA-targeted agent exposure, whereas nearly 20% of those patients in the real-world data set were exposed to BCMA-targeted agents. So what is the outcome in patients who have previously been exposed to BCMA-targeted agents? Here you can see the overall response rate. If you look at all patients with any BCMA-targeted agent, there certainly seems to be a drop in the response rate by about 10 to 15%. But if you look specifically at the type of BCMA-targeted agent used, again, ADC, bispecific, and CAR-Ts, you can see very, very small numbers, but again, you do appreciate a drop in the response rate. Of course, these are very difficult to compare because these patient profiles are very different. And when you look at the durability of response, we again see the same thing, that patients who have previously been exposed to BCMA-targeted therapy appears to have less durable response. How much of this is related to the BCMA-targeted therapy exposure versus the fact that these patients have advanced enough disease to have gone on to a second BCMA-targeted therapy remains unknown. But we do have data from some of the smaller cohorts from the prospective trials, like the CARTITUDE-2 study, where they looked at a cohort of patients who have previously been exposed to an ADC, again, small number of patients. You can see that the overall response rate is 62%, and put it in the context of the 97.9% response rate that we saw with the in the non-BCMA exposed patients in the CARTITUDE-1 trial. And the same thing has been seen when you look at the bispecific antibody bodies targeting BCMA. You can see that there's the overall response rate is lower than what we would have anticipated with this particular CAR-T-cell product. We still see a proportion of patients who get deep response, but overall it appears that we might be losing some of that efficacy here. So clearly there are a lot of limitations with the current CAR-T-cell products that we have, and I would say across the board in all hematological malignancies or other diseases where we use this particular platform, particularly so for multiple myeloma. I think as we start using these agents very late in the course of the disease, we often have patients who have very rapidly progressive disease that prevents us from being able to get the product manufactured in time. But at the same time, we have as it moves forward to the early lines of therapy, hopefully we will have patients who are in a much better shape coming into the clinical trial with a little less aggressive disease, which allows us to use treatments more effectively. There's obviously a lot of limitations related to the production platforms that are being worked upon right now. We saw a variety of presentations at ASCO and ASH looking at platforms that will allow these CAR-T-cell product to be available in a 1 to 2 week time frame, again allowing these patients with more aggressive disease to be eligible for these studies. And then, of course, a lot of efforts being targeted towards trying to reduce the CRS and the neurotoxicity associated with these products. Of course, the relapse still continues to be a major challenge, as you saw with the KarMMa-3 data, that patients continue to relapse over the time that they were observed, and we are not really seeing a plateau, unlike what we are seeing in the context of lymphoma patients. So how do we decide on eligibility for patients for CAR-T? Obviously, one of the overriding things is what is the label. And right now, almost all the patients that we are giving CAR-T outside of clinical trial are those patients with 4 prior lines of therapy. And hopefully with some of those recent data that we just saw with early lines of therapy, that will change. The second, obviously, patients, we had to have patients where we can reasonably control the disease between the apheresis and the CAR-T infusion. We generally would like to have patients with a reasonable performance status, at least 0 to 2. We want patients, again, with a reasonably good organ function. Again, given the fact that these patients can potentially get CRS, sometimes grade 3, we want to have the cardiopulmonary function that is, and renal function that will be able to withstand the impact of a high-grade CRS. And obviously, patients who have the good support system is going to be important, as many of these patients will have to be in a center for at least a month, if not more, to go through the entire process. So clearly, there are a lot of logistical considerations, not only just patient-related factors that are important. Can those patients travel, get to a larger center with cell therapy facility? Obviously, this is going to be one of the factors that is going to decide whether somebody is going to get a CAR-T therapy or a bispecific that might be in the future be more easily accessible in the community. Again, I think these are not cheap therapies, so obviously the coverage and the reimbursement is going to play a very important role in terms of who gets these treatments. And I think there's a lot that is still unknown in terms of what is the right time to harvest the cells to proceed to this. So certainly, I think right now a lot of the host factors, the labeling, as well as the side effect profile of specific products all play a role into their decision making. Certainly, there are a lot of other things we can discuss towards the end. There are a lot of unknown answers in terms of the sequencing of the same target agents, the risk-adapted therapy, whom do we select? Can we select them based on the risk? Do we need to use maintenance after CAR-T cell? And can we reinfuse CAR-T cells in people who relapse? And we'll come to that towards the end of the session. Thank you so much.
I have a question for you. Thank you very much for this very crisp presentation. Does T-cell quality, let's say in terms of the sequence of your multiple myeloma treatments, does that play a role in?
That's a good question. I mean, I don't think we know how to define the optimal T cell health for, but we do know that patients who have, especially lymphodepleting therapies in the past, we certainly seems to be able to collect and manufacture the product less efficiently in those patients. I think we have a little less idea about how much those factors play in terms of the durability of response. I think that's what we will need to find out. And it's especially important in the myeloma setting, as you pointed out, as these CAR T cells move to the earlier lines of therapy, do we really collect T cells and CD34 cells very early on in the course of the disease so that we can use maybe both stem cell transplant and CAR T cell therapy optimally?
There's one question, microphone 2, please.
Yes, Nico Gagelmann from Hamburg, Germany. Thank you for that brilliant presentation. I've got one question regarding the high-risk features. We see with EMD that the response is quite similar, but as you said, the duration of response and then progression-free survival is bad. High-risk cytogenetics, always bad. If you could choose, or if you can hypothesize, would you change your alternatives with bispecifics for these two populations? Would you give bispecifics as maintenance or before CAR T for EMD or for high cytogenetic risk?
No, I think it's an important question. I think you kind of answered that question to some extent. I think the key thing for the high-risk patients is to have some form of maintenance therapy. As you just indicated, the responses are as deep. You're getting really good debulking of the tumor. But unfortunately, these patients have really rapidly proliferative myeloma that they just bounce right back. So the question is going to be, what do we use for maintenance? Do we use a bispecific after CAR T cell, or do we use an immunomodulatory drug? Obviously, that becomes easier as we go to the earlier lines of therapy because you have drugs that have not been used. But in the late lines, I think there's not much left other than probably using a bispecific therapy.
Yeah, thank you very much for your talk.